Okay. Glad to see so many people here. We've got lots of people coming in still, but I'm going to go ahead and get us started so we can make sure we've got time for everything that we want to cover today. So welcome. Thank you for attending the 2022 Colorado Public Health Association Culture of Data Conference. My name is Julia Simhai. My pronouns are she, her, hers, and I'm the director of the Culture of Data Planning Committee this year. I'll be moderating this session, and we have Rachel Massman running the Zoom and making sure that tech is running smoothly. So if you have any tech issues, please chat with her and we can get you sorted out. Everyone is muted now. If you have questions later on for our keynote speaker, you'll be able to use the chat function or unmute at that time to ask your question. But for now, please stay muted so that we can hear our speakers clearly. If you're comfortable doing so, please add your pronouns to your Zoom name. You can do that by clicking the three dots in the corner of your video and clicking rename and then entering them in there. And we ask that you do that throughout the conference as you're comfortable so that everyone can see your pronouns. We have a great set of speakers and presentations throughout the conference and are really excited to hear from many individuals and organizations today and tomorrow. All the conference information, including the Zoom links, as you've probably figured out since you're here, is on the Schedge website. Slides and handouts are also on there, and recordings will be posted next week once they're ready. There are 2 walk and learn sessions, which are audio only presentations. So those you can step away from your computer, go for a walk or do something else and listen. They're available on demand, so you don't have to do them during those allotted times. You can listen anytime you choose, but we do hope that you check them out. There's some great content in there. We are thrilled to have you all here today with more people continuing to pour in. We have an even bigger crowd than last year's virtual conference, which is exciting. And we also expanded so that we have 3 options during each of the breakout sessions, as opposed to the 2 that we had last year. I'd like to thank the conference associate director, Allison Rosenthal, and Rachel Massman, who support CPHA from our association management company, The Solution, as well as the entire conference planning committee for their efforts. We would not have been able to get as so many attendees and expand our schedule without all of them and their hard work. And because of all that work, we have a really diverse and interesting set of presentations that align with this year's theme, which is public health, recovery, resilience, and imagining a new beginning. The last 2 years have been challenging and transformative for public health, as you all know. And while the pandemic may not be completely behind us, we are starting to see ways that communities are rebounding from its effects and seeking to address pressing public health issues, including many inequities that were exacerbated by the pandemic. So this conference seeks to explore the role of data in addressing these issues and preparing public health for its next phase. You will hear in the keynote session today a vision for transforming public health data systems at a national level. And then tomorrow in the plenary, we'll focus more locally and you'll hear about how data is transforming public health at the community level here in Colorado. And in the breakouts, we've got a wide variety of topics. You can hear from peers who are imagining new beginnings in areas ranging from assessing health to visualizing data to engaging communities and more. So we hope that these presentations and the conference as a whole will give you insight and inspiration for what's to come in our field, specifically for the use of data and how we can all contribute to using data to support the CPHA vision of creating the healthiest Colorado for everyone. So with that, I will now turn it over so that we can hear from the CPHA president, Jason Vitello. Then we'll hear from our keynote session sponsor and then get to our keynote speaker. So I will pass it to Jason to share some words and updates from CPHA.
Good morning, welcome everyone. It's nice to see some familiar faces, familiar names. Welcome to the 2022 Culture of Data Conference, I'd like to give a special shout out to Rachel Massman and the CPHA management company, The Solution. And thank you, Julia and Allison Rosenthal, our Culture of Data directors, and the Culture of Data Committee at large for making this happen. And I want to thank all of you, our attendees, our sponsors, partners, and presenters. This year's theme is public health, recovery, resilience, and imagining a new beginning. As a former therapist, by the way, I'm a much better therapist now that I no longer see patients. But as a former behavioral health clinician, I've borne witness to the triumph of the human spirit over profound injustice and trauma. I've seen countless individuals battered and bruised, but not beaten by life, exercise near superhuman resilience to bounce back from the most perilous adversity. And as I reflect upon all that has been lost and forever changed, upon the state of the field of public health, that is what gives me not just hope, but confidence that we will bounce back too. Many of us are burnt out and exhausted. Across the nation, we continue to deal with anti-public health rhetoric, backlash, and organized efforts to disempower and undermine public health at the state and local levels, in a time when we should be celebrated for our tireless and courageous efforts to ensure the health and safety of our neighbors. We continue to face down the challenges and fallout of a global pandemic, endemic racism, climate crisis, political polarization, anti-science misinformation, and disinformation campaigns. But we've got this. We are a resilient lot. If CPHA has anything to say about it, and I believe that we do, Colorado Public Health will bounce back stronger than ever. And moreover, we will be instrumental in helping to forge a recovery and a new beginning for ourselves, our communities, and all of society. Additionally, over the past 2 years, we saw disproportionately high rates of COVID-19 infection and deaths among BIPOC individuals and communities, high-profile murders of unarmed Black people by police, as well as a rise in discrimination and hate crimes against individuals of Asian descent. All of this has illuminated the historic legacy and enduring impact of racism in the United States. CPHA is committed to the strategic utilization of data to help build a community-driven public health movement to end racism and all forms of oppression and to advance equity and justice across our state. The Culture of Data Conference is designed to strengthen the use of data to support the CPHA vision of creating the healthiest Colorado for everyone, starting with our most impacted and marginalized communities. And when we talk about data, it isn't just the numbers, but the narrative behind them that we must focus on and attend to. Every raw data point we collect or share reflects the story or the lived experience of the individual lives that we are committed to improving. We in public health are stewards of those stories and understand the transformational power of narrative. And this is elemental, going all the way back to when we were sitting around the fire. Humankind has built civilizations, religions, political ideologies, and other codified frameworks through the telling and acceptance of stories. From a psychological standpoint, story making is crucial to achieving personal change. Neurologists have illustrated how sharing one's own and hearing the stories of others promotes an empathic response. Indeed, the old adage is true: the shortest distance between two people is a story. Narratives help to make sense of individual and collective meaning. They can help change hearts and minds, which in turn can help change systems and policy, which in turn can help change the material conditions of real people. And that's why we are here. When I was a practicing therapist, my favorite therapeutic orientation was strengths-based, solution-focused narrative therapy. This perspective upholds the notion that true healing can only begin when we can stop hoping for a better past and can forge ahead toward building a brighter future. It asserts that the individual is the expert of their own life and the author of their own story. And while we have no control over how our story began, we do have a say and how it ends. And we in public health believe that this holds true not just for the individual, but for our communities and indeed all of society. So again, I welcome you, co-authors of A New Beginning, to the 2022 Culture of Data Conference. Thank you.
Thank you, Jason, for those words and your ongoing leadership of CPHA. We're glad to have you here. The keynote session today has been generously sponsored by the Colorado School of Public Health, and we are very grateful for their contributions to the conference and just general ongoing support of CPHA. So here today to share more about the school is Dr. Lisa Miller. She is a professor of epidemiology and the Associate Dean for Public Health Practice at the Colorado School of Public Health. Prior to coming to the university in 2017, she worked at the Colorado Department of Public Health and Environment, where she led public health program teams in disease surveillance, investigation, control, and public health research. In her current role, she provides leadership, partnership, and expertise for the school in the area of public health practice. So please join me in welcoming Dr. Miller.
Thank you so much. And I'm so pleased to be here today. And I think you are going to share slides. There we go. All right. So again, welcome and thank you so much. And we could just go on to the next slide here. So I like to think of us all as a public health system. And as part of that system, the Colorado School of Public Health is so proud to be a sponsor of this Culture of Data conference, and particularly this keynote session. As part of this, we're in the process of adding an organizational membership with CPHA. And what that will mean is that every student, every staff member, and every professional research associate will be a member of CPHA. And that will probably be implemented this fall. We're also in the process of signing an academic public health partnership agreement with CDPHE that will further strengthen all of our activities that we do together with the State Health Department. Those partnerships, both of those partnerships really, in my mind, provide more opportunities for our students, our staff, and our faculty to become more involved in the practice of public health, so we can continue to build these relationships and continue to contribute to our public health system. Next slide. So I want to just mention a couple other things before we get to our keynote speaker. One of those is that we have so many degree options for you at the School of Public Health. We have over 50 public health specialties across our 3 campuses, and that's the Anschutz campus, the CSU campus, and the University of Northern Colorado campus. So you can really find the best fit for your career needs. I also want to mention that new this fall, we have an online certificate in American Indian and Alaska Native Health, which is very exciting. And next slide. I'll mention a couple training options. There's a lot of training options. I urge you to go to the Rocky Mountain Public Health Training Center site on the School of Public Health website and look at all the training options, but I want to highlight a couple here. We do have a free health equity online course. Unfortunately, I just learned that the one that's coming up next week is now full. That is a good thing that that's full, but there will be more options for this course. So please do check back for more options for the free health equity online course. This is a course that really aims to give public health practitioners tools so that they can start really walking the health equity walk and not just talking the health equity talk. So sometimes it's hard to know how to get started there, but this course aims to help you do that. And next slide. So the other training I wanted to highlight is of course, a data-related training. It's called Data State of Mind. This is a self-paced online, again, free training. So this is available anytime. And this is really a data training that is more practical, has easy to apply information that allows people to learn how to question and critique existing data as well as looking at how to identify, collect, and analyze data. It's really best for maybe community members or people just getting started who are in public health or behavioral health. It might be good for people who are part of a work group that's utilizing data so that they can help use that data for decision making. And next slide. So my question to you, and I hope you can help me here by putting some information into the chat or emailing me with your answer to this question. What data related training do you need to be successful in your work, whatever that is? I want to keep this very open-ended. You know, whatever that might be, I'd be very interested to understand better what your needs are as far as training. So if it's short, maybe put it in the chat. If it's longer, please feel free to email me. My email is there. You can email me with your thoughts about this question or really any practice related issue that you think is pertinent for the School of Public Health. I'd love to hear your thoughts. And next slide. So I'm gonna wrap it up there just with our contact information. Again, thank you so much for allowing the school to be part of this. Looking forward to the next session. I want to also just thank all of you for all you've done during the past few years. Know that we are your big supporters. So thank you and have a great conference.
Thank you, Dr. Miller, and thank you again to the School of Public Health for their support of the conference. Now it is my pleasure to introduce our keynote speaker, Dr. Inez Ponce. Dr. Ponce is a professor in the UCLA Fielding School of Public Health, director of the UCLA Center for Health Policy Research, and principal investigator for the California Health Interview Survey. Her research contributes to the elimination of racial, ethnic, and social disparities in health. Dr. Ponce recently served on the board of Scientific Counselors National Center for Health Statistics. She has served on committees for the National Academy of Sciences and the National Quality Forum, where her expertise has focused on setting guidance for health systems in the measurement and use of social determinants of health as tools to monitor health equity. In 2019, Ponce and her team received the Academy Health Impact Award for their contributions to population health measurement to inform public policies. In 2021, she served as a commissioner on the Robert Wood Johnson Foundation's National Commission to Transform Public Health. We are very fortunate to have Dr. Ponce here today to talk about building more resilient public health data systems that are authentic, accessible, and action-oriented. So please join me in welcoming her. And we were having a little bit of tech issues before, so it looks like we've got her video going right now, but we might have to she might have to turn her video off if it's flashing. So, but I will let her take it away.
Thank you so much. Thank you so much. And hello, Colorado. I wanted to thank the Colorado Public Health Association, to Jason Vitello and to Lisa Miller from the Colorado School of Public Health. I am based in Los Angeles area, and at UCLA, we honor and acknowledge the Gabrielino Tongva peoples, who are the traditional caretakers of the Los Angeles Basin and the South Channel Islands. So on with sharing my slides. I got the video fixed, but now let's see if the sharing slides is fixed at this point. So please. Hang on with this. Apologies, we're almost there. So my talk today is on centering health equity. Pardon me, now we're having some other problems here. Are you seeing my slides yet?
They were up for a second and they went away. So right now you're not sharing anything.
Yeah, I will, hopefully this is going to be the magic moment. And here we are. All right, thank you for your patience. I was asked to add, it is advancing
I think it might have the auto timing on. So if you
on.
go back out and at the top, go to the
Yeah,
slideshow tab.
yeah.
If you go to the tab that's slideshow, like up to the right of that where you hit home,
Right of here. Sorry.
across the very top where it says slideshow. Keep, there we go. And then uncheck use timings.
Oh, got it. Thank you so
Yeah.
much. Thanks. All right, so that's the fourth time should be. All right. Finally, so it is still advancing. So I'm wondering if perhaps you could advance my slides for me, because it's, if that's possible.
I can pull them up and share if you want to start. I can get them up in a minute.
Okay, thank you. Sorry about that. I obviously need to sign up for the Colorado School of Public Health for a training on how to share my slides, even though this is like the 50th time. So apologies for this.
If it makes you feel any better, we had a conference the other day where we had similar technical difficulties at the school. So it happens to everyone.
Yeah, I was able to fix the flashing video issue, but I think now it's I don't know why my slides are auto.
Yeah.
If you want to go ahead and get started, it's going to take me a minute to get them up and then I'll catch up to where you are.
Okay, I think I may have fixed it. So let me just, I will share. Okay, let's try this again. Okay, for the fifth time, centering equity for public health data systems. Actually, it's always important to hear it not just once, twice, but several times in really building this culture of data that we're trying to do in several local health departments, state health departments, across data ecosystems across the nation. I wanted to give thanks to one of my colleagues and a mentee, Carla Blessing, Filimo Thomas, who helped me with this presentation. So poll number one, are you a data user or a data producer? I'm a survey researcher. What's one of my areas that I spend a lot of my time on. And I'm going to force you to choose one if you are both. So let's start the poll. So Julia, if you've started it, let me know. And
Yep, it's up. We've got about 80% of people submitted so far, and it's about a 60% data user and 40% data producer split.
okay, fantastic. And 80%, that's a fabulous response rate. I was going to cut it at 50%, but this is actually a very, very engaged audience, and glad to hear that the data users are here, but also that the data producers are here to learn more from each other in this conference on how to do better. So today's talk will be on the role of data and data equity, some calls out of data failures during the COVID-19 pandemic and in general. But I think what's really important in this conversation is not so much the why, because obviously you're here today and the Colorado Public Health Association declaring racism as a public health problem, an issue that has to be addressed, that you're all already bought in and hopefully are really willing and able to figure out then what the how is. So the why, we're all there, but the how is, I think, what is the challenge of just transformation of public health systems. So along the presentation, I'll talk about lessons and recommendations. And then the future of public health is sort of a tall order. I'm not going to, or I don't purport to have the overall vision or the different intricacies that make sure that vision is operationalized. But I hope that today I'll give a portal of what we've done in California, what I've done in my career that hopefully will lead to some ideas on this transformation of public health. And the examples I give are basically really what keeps me up at night. It's the California Health Interview Survey that I run, a project I lead on race ethnicity data disaggregation. I'm glad to know that we also do this with Colorado here, with the CHAS, the Colorado Health Assessment Survey. I think Jeff Bontrager might be in the Zoom room, so hello. The American Indian Alaska Native Data Capacity Project I did a few years ago on looking at federal surveys still keeps me up at night. And then really, I think two very close to my heart projects are the Native Hawaiian and Pacific Islander Data Policy Lab and the Philippine AO Community Health Association. So both activism projects lead to better data, and I'll talk about that today. So data, is mostly surveys, EHRs, registries, claims data, COVID case and death counts, other types of data. But I think we also have to think of data as Jason so beautifully said, is about stories. It's about the pain points. It's about the celebrations of people. It's testimonies and lived experience. But, whatever it is, whatever form it is that it's data is measurement. And measurement is key to achieving health equity. I say often, no equity without data equity. And data equity is a very large part of getting at health equity and measurement. And as the CDC sees it, that there's these three roadways to get at health equity. It's about programs, it's about measurement, it's about policy. And I'm usually on the bus in this measurement roadway. But I think it's really important that as a data producer, and I do see myself as a data user and a producer, but more as a producer, that bus then has to make the stops in different communities, has to pick up all the members of different communities for us to really understand what's going on and to make sure that our measurement is more precise in depicting the experience of these communities. And data is used to uplift marginalized communities globally and locally. We've heard the term health disparities. Certainly when I started my career now over 30 years ago, that health disparities, the term just came on the scene, principally after Secretary Heckler's report on Black and minority health, which came out in the late 1980s. And this was where comparing Blacks and other minority communities with the white population. And so the term then health disparities came about. So looking at differences in health outcomes experienced by socially disadvantaged communities or populations. The Institute of Medicine then, now the National Academy of Medicine, further defined it more that a difference is not a disparity, that a disparity puts the systems more on the hook. So it's not about differences because of preferences of the patient, the communities or the culture of the communities, but it's when the differences are produced by systemic opportunities or barriers. Then there's structural inequities, which then zooms out from just the walls of the clinic and the hospitals, but it really is about the distribution of power, income, goods, and services. These structural inequities are racism, colonialism, gender bias, ableism, and it just kind of gets then at that it's about these backstory. It's about the historical inequities that then shape the health outcomes, the healthcare access, health outcomes that we see. And then social determinants of health. So these are, as a public health audience, very familiar with, and that a lot of the public health interventions then must take into account how to create programs to access to healthcare, schools, and education, and how to improve the conditions of work and leisure in people's homes, in their communities, in their towns, in their cities, so that we can assure that they have the best chances of leading a flourishing life. So the term data equity has many definitions, and this is one I like to define it as data are collected, analyzed, interpreted, and distributed such that marginalized communities have access to and use these data. So it's from the design process to the dissemination process, and it's also not just about access to the data, but it's also, I think more and more, particularly during the COVID pandemic, it's how to engage communities in like what questions are relevant to ask. Where should you, oversample? Where should you go, and which communities are emerging that you don't know about? So I think data equity in this case, so data disaggregation is part of data equity, but data equity is centering that how you're going to create the best data ecosystem is really thinking about the groups that are most left behind, the groups that are most marginalized, and how to see how you can design a data ecosystem that represents as best as possible these groups. So I'm going to go to poll number 2. Poor race ethnicity data can lead to health inequities. So in your experience, and this is now if you're a data user, so what are the main problems with race ethnicity data? So this is from a perspective of a data user, and there's at least 60% of you out there, more, because I'm sure there's overlapping data users and data producers. So in this case, you can choose all that apply.
Okay, we've got the poll up, and I'll let you know once you've got some responses to read out.
Thank you. may take long to read the responses. And these, of course, this is not an exclusive, there's I'm sure other complaints that data users may have, but I'm hoping I captured some of what I certainly hear from the data user communities that that I hang out with.
Okay, we've got about 70% participated. So
Great.
the top two, each with about 65%, where that race ethnicity data is the beginning, but does not measure racism, colonialism, discrimination, etc. And lots of missing data, and if imputed, subject to bias and assumptions. Those are the top two. And then kind of closely behind was groups that I care about are not represented in data collection or not reported in data tables, reports, tools.
Great, thank you. I think that's, I'm glad that race ethnicity data is a beginning, but does not measure racism, colonialism, discrimination, hate, and other experiences, or is now, it floats to the top of the list. Definitely in the California Health Interview Survey, we are a health survey, so we ask questions on, on how many doctor visits, do you have a usual source of care, health insurance coverage. But I think increasingly, and this is because of partners with community organizations and foundations and philanthropy that really care more about, what Bob Ross, the president and CEO of the California Endowment, has told me is it's about the power grid. So decentering from really looking at sort of the conventional measures of healthcare access, but more on societal access and this power grid of trying to get at that. So, and this includes assets as well. It includes, social capital measures. Do you feel safe in your neighborhood? Do your neighbors help you when you need something? Do you feel comfortable leaving your children with your neighborhoods? Safe when you have to go for a doctor's appointment. Voter engagement. Do you feel, and besides just voting, but do you join community organizations to try to solve community problems? So these kinds of questions now are standard in the California Health Interview Survey, and again trying to get at issues of voice, agency to improve health equity. We also have now questions on adverse childhood experiences. Justice involvement in your family, as well as questions in California. I'm not sure, maybe I think you do also have this in Colorado. Wildfires, climate, climate experiences, climate change experiences, and something that is very important across the nation. I know for Colorado and California. Recently, we've also started putting questions on gun violence prevention. So I think that this is important. And then in terms of the racism, colonialism, discrimination, we have started putting questions on, actually we've had questions, but it's changed and evolved through the years, questions on unfair treatment in getting healthcare. But also questions of, like, would you have gotten healthcare if you belong to another race or ethnic group? And so, getting at, questions of discrimination, and as I'll tell more later in the presentation, an explicit question on hate. So missing data is, I just gone to several conferences on how to deal with missing data. Is imputation good or bad? I'm happy to talk about that more in Q&A, but we do have some technical assistance, technical assistance seminars at the National Network of Health Surveys. I put at the end of resources and a whole seminar on missing data. So, okay, it's the data producer's turn now for the poll. So in your experience as a data producer, what are the main drivers of poor race ethnicity? And you can also choose all that apply.
Okay. Give it another few seconds for responses to come in.
And this is a non-exhaustive list. And if you have a problem or driver that's not here, both for this poll and the previous poll, please put it in chat.
So we've got about 55% participation. The top one right now at about 60% of people responding is lack of connections across data systems. Designers of systems don't talk to each other. And then the second place one at 55% is that legacy systems inhibit collection of more granular race ethnicity categories.
Wow, so my takeaway is that there's better response rate among the users than the producers. Another takeaway is that lack of funding or leadership will. So looks like you're in good shape if you've got leadership will. If you funding, I always hear that's the problem. The whole problem, and for among survey folks, the real estate, of course, is a constraint. But yeah, the lack of connections across data systems. I think Colorado has this opportunity because you have an all-payer data claims, you have a fabulous health survey. I'm not sure about your administrative data systems, but it's then having the resources, perhaps incentives and mandates for this connectivity, I think is a start. We talked a lot about that in the National Commission to Transform Public Health Data Systems for Robert Wood Johnson Foundation. And so I'm not the expert of that, but there's certainly some resources there too that you can look to in terms of getting some ideas. I know that it's hard with legacy systems. It's hard to what is the agreed upon ways of communicating. But it's not, as John Perlin said, it's not about machines talking to each other. You really have to start with people talking to each other, the designers talking to each other for this to happen. So, so story number one, and as Jason Vitale said, it's about stories. And so here's my story. California Health Interview Survey, and I disclosed, like you heard my bio, but really the biggest part of my bio is that I was a community advocate before I became an academic. And so I think being a community advocate made me a better data producer. But my pro tip is you don't have to be, you don't have to have the advocacy creds, and listening to communities though really helps a lot. For those of you who don't know the California Health Interview Survey, I'll just go very quickly about this. We're large, probably the largest state health survey, about 20,000. It's adults, adolescents, and kids. And it's conducted in English, Spanish, Cantonese, Mandarin, Korean, Tagalog, and Vietnamese. It is very comprehensive, as I had already shared with you. Of course, we ask about healthcare access. We ask a lot about health conditions, but we also, ask about all these other questions on the social determinants of health. But I think what's key is that people like to use our data because of all the granularity of race, ethnicity, and that we have SOGI data and social demographic data and And we respectfully ask about citizenship, immigration status. Do you have a green card or not? And the SOGI, the gender identity, we were like one of the first surveys, large scale surveys, to ask questions on gender identity and among adolescents, gender expression. So a lot of it is driven by a community of researchers, but also community-based partners and advocates. And I do want to put a plug for population health surveys, is because it is a portal on what people are experiencing, who may not make it to claims data, who may not make it to have access to the healthcare system. So it really is important of piecing this back, what I call this backstory, and some of it, historic generational backstory that may explain racial, ethnic inequities and access to and healthcare access and ultimately health outcomes. We had two main objectives in CHIS. It was to, and the National Health Interview Survey, which I love very much, did not have enough sample for California. So CHIS was started by Rick Brown, one of my mentors, and it was to provide sub-state local estimates. That was the principal piece. When I was recruited to UCLA, CHIS was my first job. And I think one of my finest moments was to crash in on a meeting where they were planning on CHIS. And I think Rick just saw that I really cared a lot about surveys. As an advocate, I complained a lot about surveys. So he let me in, and I became the co-PI at that time. And I added the second main objective, which is to measure health disparities in the state by a host of domains and experiences that lead to stratifications that we have in society. And those are listed here. But to center equity in population surveys, then you've got to have an explicit measurement objective to eliminate health inequities. And it's not enough to say we're surveillance on the health of population. It has to have this explicit measurement objective. It's got to be co-produced with partners, with community partners, and frontline folks that see what's emerging, what's going on in the community. And this is what adds value to your survey. And you've got to have this organizational commitment, and you have to have this community accountability that, we asked for your help last year, and so now we're going to present to you what we found. So I think that has to happen. And of course, what I tell the community of data producers and is that it's equity absolutely has to be at the center, but what happens is that quality ends up happening. So it's also about survey quality. It's also about data quality, because the quality of your insights then from your data will be much better in formulating and improving population health. And this is how CHIS has impacted data equity research. I mostly, I work on looking at race, ethnic, data quality, particularly in the Asian American and Native Hawaiian Pacific Islander community. But our impact has been in collecting health and sociodemographic information for Asian and NHPI subgroups per the Office of Management and Budget recommendations. I'm not going to go over that much here. I can do that in Q&A. But we do present on Latinx subgroups, American Indian, Alaska Native tribal affiliation, as I said, sexual orientation, gender identity. And in 2021, we included a writing categories for white and Black African American, so that we can capture the MENA, the Middle Eastern North African categories in our survey. So CHIS uses oversampling. Oversampling is also, so you have all these granular categories, but you may not have enough sample to present reliable data. So we do oversample. And coverage bias is a concern among survey methodologists. And so one way to address coverage bias is to administer the survey, not just in English, but the languages that your communities speak, and just is conducted in several languages. We also, sometimes probability samples aren't going to get at the smaller populations. So we recently started delving into non-probability space. It's a bit scary for my survey methodology team, but we have special surveys on Native Hawaiian Pacific Islanders and the LGBTQ community. So does all this effort matter in terms of policy insight? And this shows a kind of a maybe not be causal, but this sort of tsunami effect of studies. This is a PubMed search on Asian American studies insights. And in this case, what it shows is that I don't know if I'm going to have the yes. That when CHIS came on the scene around, 2001, that there was, just kind of a handful of studies on Asian Americans, Native Hawaiian Pacific Islanders, but then you see this kind of tsunami effect, and it's not all CHIS, but it's mostly CHIS. It's about 70% CHIS of these PubMed studies, and so it shows that having better data and making sure it just doesn't sit on the shelf. So there's a lot of promotion that had to occur, where I met with researchers to say, hey, this data set now is in the field, please use it. That it does then show that now these insights on Asian Americans in particular, grew after. Down here, I have some kind of key legislation, both at the federal level, that perhaps helped with increasing data on race, ethnicity. But my point here is that guidelines are necessary, but they're not sufficient. You also need state guidelines. There's at least 5 states now that have data disaggregation mandates, California being one of them. And this, I think, would be helpful then in showing that research community resources and better data sets will spur studies for better insights on the population. So I'm going to go, because of time, really just go quickly on these slides, but that having at the minimum the OMB guidelines of race ethnicity, which are 5 races, American Indian, Alaska Native, Native Hawaiian Pacific Islander, Asian, Native whites are really important in the Hispanic, non-Hispanic, non-Latino, non-Latino category. And so that then gets at this measurement of health disparities, and we certainly see that in California. But it's also, with the pandemic, it wasn't just about our survey, but we also wanted to make sure that data got into the hands of decision makers, of advocates related to COVID-19. And so, probably many of you here, we started just doing dashboards, and where we would just, a lot of them from local health departments, from state departments, to get at COVID rates and risk factors, but we wanted to add social determinants of health. So we used the CHIS data and attach it to the rates and risk factors that we were seeing and getting from public health departments. Just quick view, how the data is presented is important. So we have dashboards with filters, but then we also wanted to make sure that that the stories, so infographics, then were a way then of showing some of this data that's readily accessible for community organizations. And in highlighting where there were really significant pain points in the population. So what we found was that race, ethnicity, and unfair treatment during the pandemic were the highest among the Black population in California and the Asian population. So the portion was much higher in 2020. And the result of this feeling of unfair treatment, then because of race, ethnicity during COVID-19 were associated with higher rates of suicidal thoughts and likely serious psychological distress. So again, as many of us know here, a mental health crisis occurred, and certainly the feelings of hate, of discrimination fueled some of that crisis. So another project that occurred was a special collaboration. So with the Asian American Studies Center, I'm a health economist by training, and it was important to connect with scholars from ethnic studies departments who really understand more of these structural inequities in some ways, know more of those narratives, to partner with them. And so with the Asian American Studies scholars, we launched a special impact of COVID-19 on Asians, Native Hawaiians, Pacific Islanders in California. And I think the key takeaway here is that we've heard of the anti-Asian hate incidents, and certainly in California, it was like in the thousands. But if you think about from a population health survey, when we asked about, did you report or did you directly experience or witness another an Asian, Native Hawaiian, or Pacific Islander being treated unfairly due to their race, ethnic, or national origin, that's about 25% of the population. And with 6 million Asians and Native Hawaiians in California and Pacific Islanders, that's about 1.5 million. So certainly the population-based level, that the Asian hate that people were experiencing, that we were seeing in registries, that it was definitely much more when we look at it through a population lens. And so we see also that among Asian Americans, Native Hawaiians, Pacific Islanders, that there were higher rates of directly experiencing or witnessing among women. So what keeps me up at night is data disaggregation. It's like a 30-year journey. I complained about it back in 1990, still continue to complain about it. I think it's a little better. So just very quickly, I talked about our technical assistance project, also funded by the Robert Wood Johnson Foundation. And I have the link here. I'll put it in chat once I get off the presentation mode. But we have some technical assistance seminars, imputation, being one of them. Weighting is another one. How to collect. We have that, and that's archived. So one of the first projects that we had in this National Network of Health Surveys and our data disaggregation project was funded by ASPE. It's the U.S. Office of the Assistant Secretary for Planning and Evaluation. And they wanted us to look at several federal data sets as well as CHIS to look at how the tabulation, the coding of American Indians, Alaska Native was in these data sets. Most of you probably know BRFIS and the National Health Interview Survey and Ann Haynes, but also National Survey of Children's Health. Medicare Current Beneficiary Survey, which is out of CMS, was one, and NISDA out of SAMHSA, it's National Survey of Drug Use and Health. PATH is a tobacco survey that's longitudinal, and then comparing it to CHIS. So we looked at the restricted data that they do have the 4 possible ways of tabulating American Indian, Alaska Native, which are really important to get at insights on this group because it's one of the highest multiracial population groups, and also has one of the highest that also report Latino, Hispanic ethnicity. And the problem with that in California, for example, is that we have a Latino trumps all tabulation rule. So which makes sense and it doesn't really affect the other a lot of the other racial groups. But for the American Indian Alaska Native groups, where say 50% report Latino Hispanic heritage because California was part of Mexico, then it really minimizes then the sample of or insights on the American Indian Alaska Native group. So the flexibility of the reporting of that group is really important. And this is why we did the evaluation of, do we have these groups of non-Latino, AIAN only, Latino AIAN only, and then combination or any mention. So in the restricted data, the good news is that, assuming you have resources and the wherewithal to get and the time to wait and get at restricted data, that these data sets have this for flexibility in reporting for this group. But when you look at the public use data, which really is what fuels a lot of the publications and as and PubMed access to that's really important. But for public use data, that then it's a different story that you see that very few actually have any mention of American Indian Alaska Native. And what then you see with this, what this means then is that that most of the public use databases are going to provide limited or no data information, and that most of these insights about the AIAN population are only going to be based on single race non-Latino AIAN. So I think it's one aspect that it's fine, like if you were to produce that, but to make sure that when you're looking at data sets or when you're writing about populations, that you're very specific on what populations that you are reporting about, particularly for the AIAN populations, that you would say for the AIAN population nationwide should be for single race, non-Latino AIAN population. This is what we're seeing. But our takeaways here and our recommendations, which we provided to ASPE, is that access is a problem, because if your population is not in public use files, then the insights are going to be limited. And so the larger groups where we have then public use files, then there's more insights on those groups. So we suggest that you release, for those data producers here, pooled multi-year files that include more detailed race ethnicity data. You include information overall AIAN population. And some of these federal data sets did not even include American Indian Alaska Native in the weighting process. So that's really important. And then it's the transaction costs of getting data. So reduce the cost and time for accessing data. We had to access this data, and it took us over 6 months and a big grant to access this data. So, think about then what that would be, this transaction cost would be for community groups. I think then moving on to the Native Hawaiian Pacific Islander population, which is my story number 3, is last week, PBS NewsHour featured the lab and the lab's impact on the Marshallese community in COVID in Arkansas. And it was about inconsistent data and how, this really masked the pandemic's toll on Native Hawaiians and Pacific Islanders. Melissa Leilan is an advocate, fierce advocate there for the Marshallese community in Arkansas, in Springdale, Arkansas. And she noted that she could see the pain it was causing in her Marshallese community, but until the work of the Native Hawaiian Pacific Islander Data Policy Lab at UCLA, they didn't have the data to prove the need. So we actually produced dashboards where we featured, and these are 9 states that rank, case rate by race, ethnicity. Thankfully, Arkansas is no longer, recent data shows Arkansas is no longer in the top 9. It always was like unfortunately, in this top 9 ranking. But we would create these dashboards and actually work with community advocates in how to interpret these and what languages to use, and then helping, in the case with Melissa, in helping with writing the press releases and writing writing the kind of the policy suggestions using the data. And so it's another disaggregation story. The quick thing here is that the COVID death rate, if you were to aggregate Asians and Native Hawaiian Pacific Islanders together, which is done in many states, which they shouldn't, is 75 per 100,000. But when you disaggregate, then the Native Hawaiian Pacific Islander population is 123, so much higher. Again, aggregation masks, and even within the NHPI community, you've got the Samoan population with much higher death rates. So again, disaggregation necessary to really understand the toll on different communities. So our recommendation is follow the OMB guidelines, but it's a floor. Further granularity is encouraged. And there's a balance, of course, of disclosure risk and presenting granular data. And I'm happy to talk about that more again in the Q&A. We do suggest that you can have intermediate aggregation categories for, like, you don't necessarily have all the 21 Asian categories that you have in the census, or the 10 or so for the Native Hawaiian Pacific Islander categories, but you can aggregate in intermediate categories. So the last piece, I know I'm running short on time here, is a Philippine XAO community. And I only started working on Filipino-specific issues really during the COVID-19 pandemic. In my career as an academic, some of you maybe here know about this, but it's, you know, you're kind of told not to focus on your communities in creating insights, because perhaps it might be too close, you might be biased, you know. So I actually worked on larger population issues, but it wasn't till the pandemic that I started to focus specifically on the Philippine XAO community. And part of it was I was moved by this memorial that was put, it's called Kanlungan, and it's honor, visibility, and recognition. And it's a memorial to the fallen Filipino healthcare workers in the US and globally, done totally by volunteer and through looking at Facebook and looking at GoFundMe and Instagram, and like really, you know, looking at stories that were heard, that they created their own elegy of a tribute to the fallen Filipino health workers. But at the time when I saw this, I could not have known about the toll on the Filipino workers. And so I started digging deeper and asked for restricted data. And in getting restricted data in California, among healthcare workers, the death to case, so it's like a case fatality rate from COVID and among healthcare workers, was highest among Asians in the aggregate. So that was the highest. But if you unpack that most of it, that there was very, very high case rates among Filipinos. Again, wouldn't know that in public use data. Again, further disaggregation, if we look here at healthcare workers, that Filipinos make up 3% of the healthcare workforce population, but 31% of the COVID-19 deaths. So, but again, I had to use restricted data. And the other upside of starting this Philippine XAO Community Health Association, which is multi-generational, mostly tilts on the younger generation, is that a lot of community engagement, information, sharing podcasts, and they're public health professionals that just wanted to do something. And so we had a podcast that I know Jason knows. It's called Psst, which is Filipinos sharing stories together. It's an inside joke among Filipinos. And what keeps me going is this data infrastructure, how to build better. I'm never satisfied that we've built the best, or because, if things change, and community academic partnerships are absolutely important. And the technical assistance and pipeline building This is my colleague, Melanie Sabato-Liwag, who's an assistant professor and director of a young, wonderful scholar. So it just heartened them to collaborate with young scholars. And we just put out a paper on the racism and health issue of health affairs, on the connections of racism and colonialism in the Filipinx community. So these are very, top line recommendations from the commission. And I'm sure most of you know this now. So I gave you the details, but I'm zooming out that we got to tell stories of the health of the people and communities, and so that equity informs this meaningful narrative change. And the governance of our data infrastructure to put equity at the center. So I don't own the CHIS data, but it really is, the community owns it. And I do try to convey that. And the sponsors, the funders don't know it. So we do try to convey that to the community. And we ensure that increasingly the public health measurement captures and addresses structural racism and other inequities. Certainly that was number one in our poll here. And again, for Q&A, I'm happy to talk more about that now. So accessibility, just takeaways, democratize the data. Make it as accessible as possible among data users. I know I took out, Carla, my colleague, put make data free for everyone, including restricted data, and I had to take that out. That cannot happen. There's data disclosure risks happening, and there's costs, there's real costs of making that happen. But definitely be community driven and intentionally include the community in all aspects. And I end with the reflection of authenticity. And as a researcher, as a data producer, as a data custodian, that we got to like check in, do our own check-in about our own implicit biases and your thoughts about the communities and stereotypes you may have. And like I tell you, when I talked about, I'm working with an NHPI community in some public forums, some of them say, why? They're so happy. They live in beautiful places. It's sunny, it's island places. So, check in like what your stereotypes are and how will that impact your interpretations. But I think the more you have forums like this, the more you have technical assistance that's provided, like what Lisa Miller had said, then I think that's definitely a start. And so I end with some really, if I can get the resources that we have. Please check out healthpolicy.ucla.edu. It's the center that I run, chis.ucla.edu, California Interview Survey, the Health Survey Network that I talked about, which has some archived resources. And then, follow us in these social media posts. So thank you. I apologize for all of the tech issues in the very beginning.
No problem. Thank you so much for your presentation and the stories that you shared. Lots of great ideas there. We have about 5 minutes for Q&A. So as I put in the chat, feel free to enter questions into the chat if you have them. If you prefer to unmute and ask your question, you can do that as well. So I'll pause there and see what we get from the audience. While we're waiting for other ones to come in, I can ask one. I really liked how you talked about that you have to, it's not okay to just say you're doing surveillance, and that you really need to think about what equity is and how the data will be used. And then you sort of follow that up later and said that you went out and talked with researchers about using the California Health Interview Survey data. And so I'm wondering if you can just share any insights from that process of going out to convince people to use that data. Like what does that look like as a researcher?
Well, so when we first started in 2000, it was convening like breakfast of champions. Like we convened breakfast. We went to, we convened one for the Latino community, for the AIN community, for the Black African American community, and for the Asian community. So we would host these conferences, but it still was within our networks, right? So it's still within our networks as academics to reach to researchers, but we would have it in, in forum. We would have it in the communities. We wouldn't have it at UCLA, but we would have it, say, at the Museum of Latin American Art in Long Beach, right? So we would like try to have distill connection and for researchers, and then we would talk about just. So it was those types of conversations, and that was back in 2000. Now it'd be podcasts, right? So now to scale it up, it would be podcasts and working with community organizations, of course, presenting at APHA, presenting in conferences to say, hey, this new data is out. We don't want it to sit on the shelf. Let's use it.
Great, thank you. We've got one that asks, how are you using this data to impact and support these communities to decrease the amount of health disparities in the communities?
Thank you. So, I mean, the most recent example was what I said was last week. PBS NewsHour featured us, and featured the toll on the Marshallese community. But they first came to us though and had heard about the lab, NHPI Data Policy Lab, and the data and that we were doing. We don't do it as we were doing weekly, like most dashboards, which was daily or biweekly. And so from that conversation, they asked us, well, give us some examples. Are people using this dashboard? And so we gave them a few examples that were happening locally. One in the Southern California area was that the dashboard helped what we call the Inland Empire, which is Riverside County and San Bernardino County, which is sort of a desert in terms of public health resources. That helped with getting an equity grant and for them, for outreach and for vaccination pop-ups at that time. So that was one. And we have actually a bunch of case studies that we've put together for our Robert Wood Johnson Foundation, which I hope we're going to air out more to the larger public. And then the example that I gave in my talk where we worked with the Marshallese community in Arkansas and the advocates there, and then they were able to, in that story, so they were able then to get public policy resources into addressing the COVID pandemic for the Marshallese community. A lot of it was related to protections in the workforce. They were most of the Marshallese community were working in meatpacking plants. And so adding that the workforce protections and having vaccine pop-ups near those areas and in language was really important. It also helped with, it's a larger story, but there was, the Marshallese are COFA immigrants, Compact of Freely Associated States, and some states do not, and not until December, recently in December 2020, that COFA immigrants now can avail of Medicaid, and they couldn't. So it was this double whammy of penalty, with workplace, like getting COVID in meatpacking industries, but yet they couldn't get Medicaid to get care. So I'm not attributing it to us, but I think the data helped with reducing these disparities. And thank you for that question.
Thank you. So we are right at the time for our session. I want to make a few quick announcements. So thank you again for your presentation and your time today. We really appreciate hearing from you. And thanks to all of you for attending this session and engaging with us. A few short announcements. The first breakouts will start at 1 p.m. Mountain Time. So it's been about 10 minutes. Full schedule is on the Sketch website, so you can look at which one you want to attend. You will receive a conference evaluation form via email after the conference is over tomorrow. So please fill that out, even if you only attend a portion of the conference, because it's very helpful for our planning committee. And there is a raffle for 2 people who complete the survey. You could win a $50 gift card. And I look forward to seeing you all in upcoming breakout sessions throughout the afternoon and tomorrow, as well as the plenary we have from 9 to 10 a.m. tomorrow. So thank you again to our speaker. Thanks for your time and your insights, and enjoy the rest of the conference, everybody.